It's a pleasure for me to talk about this topic, and in particular, not about our data, but on tips and tricks, because, as you said, experience of intraoperative ultrasound in gynecology is really few. It is not very well described, actually. So it's important to share our tips. We started working with Canon, with the intraoperative system, in 2017, sorry. So around 3 years ago. And in our experience, we would suggest that intraoperative ultrasound examiner should be aware, of course, of the equipment. We use several probes, of course, laparoscopic probes, which is quite new, the transvaginal one, and the laparotomic ones that can be convex or linear. The use and the functionality of transvaginal or laparotomics is quite intuitive, while the laparoscopic one is less intuitive. So there is a part of the probe where you can hold the probe, and you can rotate the probe and flex the probe. The transducer is at the end of the instrument, and in this part there is the bending section. And you can bend the probe laterally or frontally, and you can also, of course, rotate it. Here is a video with Floriana. I don't know how many of you know Floriana, showing you how it works. You can flex it laterally and then rotate it. She's flexing the probe. She can rotate the probe. And in the finger probe, well, the use is really intuitive, and you can scan very, very accurately the abdomen. So for each surgical approach, we have different probes. Mainly in endoscopic surgery, we will use laparoscopic probe or transvaginal probe, while during open surgery, we have the laparotomic probe. Just a little digression about the importance and the current use of minimally invasive surgery, even in oncology. There are several studies that demonstrate the same oncological outcome in patients undergoing minimal invasive and open surgery, in particular in a set of patients, and in this case, in this study, the authors concluded that the oncological outcome in recurrent ovarian cancer is similar in some settings between patients undergoing open or minimally invasive surgery, but of course, they achieved a decrease of morbidity. And we already had a study in our department on the possible role of intraoperative ultrasound in these patients with recurrent ovarian cancer. And in 12 cases, the surgeon asked for intraoperative ultrasound to complete surgery, and in all cases, the examiner allowed the surgeon to complete all surgery with a minimally invasive approach, avoiding the laparotomical conversion. So we started our experience in this way. Well, in intraoperative ultrasound, we have two main protagonists, the ultrasound examiner and the surgeon. The ultrasound examiner, in our opinion, should be aware of the clinical case. It's important to study preoperative images before starting intraoperative ultrasound, just to be able to find the same lesion, to be sure that it's the same lesion, and to compare the images. This is tricky. This is very important. Also, Jasbeck told us yesterday the importance of some skills, in particular in view orientation. Usually an ultrasound examiner used to scan only preoperatively patients and do not very often go to surgery room. But it's very important that the ultrasound examiner can orientate the vision with the camera while performing intraoperative ultrasound. Otherwise, it won't be very helpful. So some skills with the camera. And of course, must understand immediately which is the most appropriate sonographic approach to the specific case. On the other side, the surgeon should be, of course, aware of potentiality and limits of ultrasound examination. So some skills in ultrasound is absolutely necessary. And Professor Exacuso suggested that the surgeon itself should perform intraoperative ultrasound, and I absolutely agree with her. But it is not usual. So sometimes the surgeon asks us very impossible things to be diagnosed with ultrasound. So they should be skilled in ultrasound, in my opinion. And of course, the best would be if the surgeon could plan intraoperative ultrasound examination before surgery. However, it doesn't always happen. So at least he should be able to call the examiner in the best surgical time, not after opening completely the retroperitoneum or causing bleeding. Of course, the best result is achieved with a good communication between the ultrasound examiner and the surgeon. This is my husband, so maybe we have enough good communication. Okay, so some images. How we do that? Let's start with the laparoscopic probe because it's the less used one. It's important to remember that the laparoscopic probe is 10 millimeter in size. Therefore, it requests a 10 millimeter trocar to be introduced in the abdomen. So this is the setting of the most frequent laparoscopic approach, with one 10 millimeter trocar in the transumbilical region and three 5 millimeter ancillary trocars. And usually the 10 millimeter trocar is dedicated to the camera. So after starting surgery in laparoscopy in this setting, if the surgeon asks for an intraoperative ultrasound with laparoscopic probe, we have to choose if to insert a second 10 millimeter trocar or to use a 5 millimeter camera. If we choose to add another 10 millimeter trocar, we can place it on the suprapubic region or in the lateral side, left or right, following our request. This is an example of two 10 millimeter trocars, one in the umbilicus and one in the suprapubic region. Of course, if we choose to position two 10 millimeter trocar, we can switch the camera and the probe as following our necessity. This is another example of the 2 millimeter trocar, one located in the umbilicus and one in the right iliac region. And this is the view. This is sigma uterus, and this is the probe inserted in the right 10 millimeter trocar, scanning an external iliac vessel. Otherwise, if we switch the instruments, we will have another vision and we will be able to scan with the probe inserted in the transumbilical trocar the left iliac region. I will show you some videos. The most challenging thing while performing intraoperative ultrasound with the laparoscopic probe is that the ultrasound examiner needs to follow in the same time the image of the camera, so laparoscopic image, and ultrasound image. In the same moment, it needs to push a lot the probe against the tissue that want to be studied, because otherwise we will have air interposition. So you have to follow two screens and to use both your hands and push a lot with the probe. So it's quite hard. This is an example with the probe in the right trocar. As you can see, the operator is scanning the right external iliac region, and as soon as he stops to push a lot, the image, of course, won't be so clear. But when he pushes, look, it's very, very accurately defined. In this case, we have the probe in the transumbilical trocar, and the operator is scanning the external iliac region, but you can go deeply and scan also the internal iliac region. You can scan all the abdomen, but you just have to choose the correct trocar to insert the probe. Of course, intraoperative ultrasound with laparoscopic probe allow the operator to study some anatomic areas very hard to be studied even in laparoscopy, like in this patient with a little recurrence of ovarian tumor just upon the left kidney, as you can see, or this other patient with a single recurrence of ovarian cancer between the kidney and the spleen, which is located here. Both lesions were not visible during laparoscopy, but before to open the patient, they wanted to be sure that the recurrence was present. Another problem is caused by protruding lesion into the peritoneum with a convex surface. Sorry. Here is the operator trying to scan this protruding lesion. It was a metastatic lymph node. As you can see, they try to push, but the probe will move. And in this case, we will have air interposition that will not allow us to study the image. But as soon as we rotate a bit the probe, we will avoid several artifacts, and we will study all the other vessels, looking for other retroperitoneal lymph nodes. The image is very accurate. Okay, I will show you just a complete case where actually intraoperative examination was really important to complete surgery only with minimal invasive approach. This was a 55-year-old patient with a mutation. She should only underwent prophylactic anesthectomy. But the main problem was that the patient already underwent hysterectomy for cervical cancer and also radiotherapy. And subsequently, she also underwent to laparotomy for bowel resection. So the indication to intraoperative ultrasound was that the surgeon couldn't find ovaries at all, because as you can see, there were a lot of adhesion. After removing some adhesion, they could find the left adnex, this is the salpinx, and they could remove it. However, the right one was absolutely not visible, as you can see. So they asked for intraoperative ultrasound examination. This is the probe inside the 10mm trocar. We were scanning the right pelvic wall, and we found the little ovary just adherent to the psoas muscle. We helped the surgeon to find it. As you can see, the surgeon is pushing just next to the probe. We said, okay, it's here. You will find it absolutely here. So the surgeon could remove a normal ovary. It would be a pity to convert the patient just for reducing surgery. Okay, just 2 words about the robot-assisted approach. Same probe, but what changes is the distribution of the trocars. In robotic surgery, we have 5 trocars. 4 of them are 8mm in diameter, so too little for the probe, and only 1 will be 10mm in diameter, and is located always in the subcostal, left subcostal region. These are the other trocars, and this is the 10mm trocar. So when we insert our probe in this trocar, you could think that it's too far from the pelvis to allow scanning of the pelvis. I want to show you that you need 2 hands to manage the probe. With the left hand, we move it, and with the right hand, we keep it flexed. When you insert the probe in the subcostal region, we can reach both left and right iliac area. Only if the patient is really obese, we experience that we couldn't arrive to that region. Okay. Let's go on. I don't know how much time will last. 8 minutes. Wow. Okay. The transvaginal probe. Very intuitive. Of course, you can imagine that the problem is the pneumoperitoneum, so the presence of the air that will create a lot of artifact. Like in this case, we were scanning. We've been asked for intraoperative ultrasound examination. As you can see, nothing is visible. However, we could find at the end our ovary. In these cases, we can ask the surgeon to push the ovary against peritoneum in the pelvis, or introduce saline solution in the peritoneal cavity, as Jacek told us yesterday. However, if you do that in the very beginning of surgery, you will have no problems. But if you do that after starting surgery, when you fill the pelvis with saline solution, it will be full of blood and the surgeon won't be able to follow you during your ultrasound. So it's important to start it early. A little example of what I'm saying. In this case, we have a very, very little benign cyst inside the left ovary. As you can see, the surgeon is pushing the ovary, and in this way we can scan it and follow the surgeon and helping him to find the very little lesion. It was a dermoid. We didn't indicate surgery, but she was young, her mother was so anxious, and so she has to remove it. Okay, this is the little cyst. And then we've been asked to scan the ovary after the removal of the cyst. In that case, we fulfill the pelvis with saline solution. As you can see, it's completely red. But in this way, we could scan the ovary and see that was a normal ovary after the removal. Okay, if the lesion that need to be found during surgery is located in the retroperitoneum, in the pelvic retroperitoneum, we don't need to fulfill the pelvis with the fluid or to push tissue. As I will show you, in this case, the surgeon couldn't find the recurrence in this patient. This is the paravesical space, external leak vessel, and the rectum. This is the recurrence. We knew that there was the recurrence, so we helped the surgeon to find it. As you can see, it's pushing. You can see it in the ultrasound image. So we could help the surgeon to find it and then to remove it. Okay, in laparotomy, it's, as I said, quite intuitive. Just one tip. Try to plan this intraoperative ultrasound examination, because if you start your intraoperative ultrasound examination after the opening of retroperitoneum, there you will have so many artifacts. So it will be very useful to try to understand and to plan intraoperative ultrasound examination. With a finger probe, we can absolutely accurately scan aortic region, as I will show you in this video. It's very easy to use this probe. While we go up and down, as you can see, the aortic region is very well visualized. This patient had metastatic lymph node, and we were studying it. If you need to scan the upper part of the aortic region, you can ask to the surgeon to move the mesenteric root, and then you go up. Just to show you how accurate is the image. You see the intima of the aorta. And this was the metastatic lymph node. Of course, it is really useful with the not visible lesion, like in this patient. This is the liver, this is the diaphragm. She underwent cytoreduction for ovarian cancer, but on CT scan, this lesion was described, and to find it, we used the finger probe. So we can conclude that sorry for this image. This is Italy 2006, and now I remember that it was in Berlin, so maybe it's quite appropriate. So intraoperative ultrasound scan can improve surgical procedure. For us, it's a success. And it is useful both in conservative and radical surgery, of course. What is important, before start ultrasound, as I said, it's important to study the patient. You have to know what are you looking for. Not only ask to the surgeon what he needs, but you have to be aware of the situation, of course, and you have to prepare necessary equipment. You immediately have to know if you need another trocar, if you need the cover probe, what do you need? Because surgeons do not want to lose time. Okay, so the situation will be not very comfortable. And collaboration with the surgeon is fundamental. Thank you.